So now we move to another session, very important session again, and another clinical syndrome which is observed practically every other day in the clinical practice, and that is reversible dementia. Now, for reversible dementia, we have a very good speaker with us, Dr. Mukesh Kumar. He is lot experienced with reversible dementia, and I would invite Dr. Behra as a chairperson for this session. Dr. R.K. Behra. Yes, sir.
Hello.
Yes, Dr. Behra, I
Yes,
want you to introduce Dr. Mukesh Kumar, please.
Yes, sir. Dr. Mukesh Kumar is MD DM in neurology. He is associate director and head of Parkinson's disease unit. Inspiring neurologist. He got Inspiring Neurologist Award 2019 by Economic Times in 2019. His Best Innovative Teachers Award also in 2019 by ANBAI New Delhi. He is raising public awareness by radio, by TV, and talk shows. He will give a wonderful talk.
Thank you, Dr. Behra. I invite Dr. Mukesh Kumar to please proceed with the topic, very interesting topic of
Yes, sir.
reversible dementia.
Is this screen visible, sir?
Yes, yes.
Yes. So, thank you, sir. Thank you, Dr. Anand. This giving me this opportunity to present a very unique and new topics, which is a reversible dementia. And I have seen a lot of change in the management of reversible dementia in last 10 years. So, reversible dementia, is the screen is visible, sir? Hello?
Yes, it is visible, sir.
So this is one of our case, which is a young girl, which she presented with dementia, and screen sharing is paused. What happened? Hello, I'm not, just a minute.
Dr. Mukesh, just click on the slide itself and the slide will move.
Okay. So this is a case of a young girl presented with a young onset dementia, and after treatment, she is able to do the painting. Okay. So whenever we talk of the dementia, it requires a neuroimaging and other biochemical tests to exclude the possibility of any reversible causes. So brain is four parts. If you see this, the first thing is the frontal lobe, then it is a parietal lobe, occipital lobe, and temporal lobe. So the frontal lobe is mainly meant for your human-like behavior. Parietal lobe is for orientation, and temporal lobe is for memory, and occipital lobe for the visual space, visual memory. So what's the lower function? Lower function, if you see this, a parietal lobe is for this how to identify an object. Then there is a temporal lobe, which is mainly for the calculations and numbers, and the Sudoku-like system, which is controlled by the temporal lobe. And the other processing is like amygdala going to the frontal cortex, precortex cortex, then parietal lobe, then occipital lobe, and all integration through fibers, association fibers, and corpus callosum. So what happened to lower function? The frontal lobe syndrome leads to lower libido, risky actions, weakness on one side of face, depression, diminished taste, behavior changes, and early distraction. And this imaging, which shows a coordination of the memory, which start from the hippocampus and involve almost each and every part of the brain in this processing. So brain function, if you see, it leads to a frontal lobe, which behavior, intelligence, memory, movement, memory and movement, and temporal lobe is for behavior, hearing, memory, speech, and vision. Then brainstem is for blood pressure, breathing, swallowing, consciousness, and heartbeat. Cerebellum is for balance and coordination. Occipital lobe for vision. and then parietal lobe for orientation, language, reading, and sensation. So electrical function of the brain, it gives you it is a combination of synapses, and electrical firing involves each and every neurons, and the integration of this electrical firing leads to overall processing, brain processing, and our behavior and our intellect. So the microscopically, it is involved by the beta amyloid, which is involved with the tau proteins, and then it leads to a damage of the apoptosis of the neurons, and that leads to dementia. So in pathological, if you see the normal brain, there is Alzheimer. In Alzheimer disease, there is a gradual degeneration of the brain, and that leads to a further fall, and it is an apoptosis related event. So regarding dementia, dementia is defined as any memory loss, any forgetfulness, which is associated with either one aphasia, language disturbance, apraxia, in impaired ability to carry out motor activities, agnosia, the failure to recognize or identifying object, and any disturbance in executive function in form of planning, organization, sequencing, and abstracting. And it should not be involved in delirium, and it should persist for more than 3 months. Then only we will evaluate a definition with exclusion of any other systemic psychiatric possibility. The causes are mainly two: degenerative, irreversible, progressive, and other is reversible. Degenerative, progressive is Alzheimer's disease, frontotemporal dementia, Lewy body dementia, and vascular dementia. Reversible dementia are surgical causes are subdural hematoma, normal pressure hydrocephalus, intracranial tumor, and intracranial abscess, or other brain infection. Infections in form of meningitis, encephalitis, cerebral vasculitis, neurosyphilis, Lyme disease, Whipple disease, sarcoidosis, and the recently upcoming entity which is termed as autoimmune encephalitis. Metabolic condition is hypo and hyperthyroidism, Hashimoto encephalitis, hypo and hyperparathyroidism, pituitary insufficiency, Cushing disease, Addison's disease, hypoglycemia, vitamin deficiency, chronic liver failure, chronic respiratory failure, chronic renal failure, and Wilson's disease. And other possibility: epilepsy, depression, drugs, alcohol abuse, and limbic encephalitis. So these are the mainly where we see a short history of dementia. It may be within a week presentation, or it may be presentation within 6 months, and patient deteriorating from a complete normal independent to almost wheelchair bound or almost bed bound within a few in a span of weeks to months. So I am now presenting one of a few 4 cases where we found a very different etiology and complete reversal a bit within a month or 2 months of treatment. This 12-year-old girl, one case, is presented with seizure and deterioration in the consciousness, is so-called that she has unable to eat, unable to diagram, unable to draw, unable to do any other activity, even speech is handicapped. And it was evolving over a period of last 1.5 years, but rapid deterioration in last 1 month. And EEG showed some temporary epilepsy. So this examination, this movement is saying the seizure plus you can see the face. There is less interactions. She look blank and unable to converse with the family members or surroundings. This EEG showed some discharges left side, and the imaging PET CT you can see there is a left side of the brain is showing a hyperactivity, which is suggestive of indirect activity, but CT and MRI is normal. So here we found a 12-year-old girl with seizure and rapid deterioration or young onset dementia with PET CT showing some high-end activity of the left sided of the body, leading to aphasia and loss of sense response. So we have done the extensive evaluation, and we found the NMDA receptor, which is N-methyl D-aspartate receptor antibody, which came out to be positive, 3+ positive in both serum as well as the CSF. So final diagnosis was autoimmune encephalitis. She received solomedol and IVIG, and followed by rituximab, and over a 1.5 months period, her diagram recovered, speech came, and she almost back to her normal routine activities. She is back to school. So this is one of the dramatic change with extensive evaluation and diagnosis of reversible dementia. Second case, there is a C is a 67-year-old female presented with hallucination, abusive language. All started by January, and she came to OPD with wheelchair, and you can see, and this lady is around February. She is doing this psychotic activity, more worshipping and frequent worshipping, and unable to attend the social circumstances. And this imaging shows a hypoperfusion of the PET CT, no other malignancy but hypoperfusion in this area. And her paraneoplastic workup shows anti-hypophysin is positive, and she was finally labeled as paraneoplastic encephalitis. And she was treated with solomedol, and she recovered to this extent. She was able to do her normal routine activity, which was not able to do before this admission. In third case, this is a industrialist. This 84-year gentleman has a cognitive decline for last 2 months, and he was chairing the meetings, but not able to chair the meeting, and social withdrawal was there in last 2 months, along with postural hypertension, which examination shows a postural fall of more than 30 millimeter of mercury in systolic blood pressure and ataxic gait. The hypometabolism is seen in bilateral parietal lobe, and the CSF reports and is saying anti-JIK4 antibody is positive. So it is also treated as paraneoplastic, and patient recovered with IVIG and solomedrol. The last case, this is a 60 years old lady. This started with January with withdrawal behavior, almost urine incontinence since last 15 days, with past history of type 2 diabetes. Examination revealed ataxic spastic gait. Just as for this finding, you can see. She has difficulty in standing and walking. Her MRI shows infarct, stroke, multi-strokes. Initially, we thought of vascular multi-infarct state, but as we do then the CSF as an exclusion, it found to be cryptococcal meningitis, cryptococcal antigen was positive. So the final diagnosis is cryptococcal meningitis. We have started on amphotericin B, and she is stable in last 2 weeks. So how to approach any cases of dementia in elderly or in children and any age group? The most important thing is what's the history. Is it a short history or is it a long history? Is it a rapid progression? Is there any associated seizure, hemiparesis, aphasia, visual complaint? Is there any fever or headache or ventricular pressure, or a history of autoimmune disease? All this should be excluded. Then we should find out the some necrosity, lobar dysfunction, and other organ dysfunction. And after that, we have to go for an biochemical test, imaging, neuroimaging, biochemical test, CSF test, and then we label it or find out the cause. In specific cases, we have to go, particularly since suspicion of primary CNS lymphoma, or in cases of meningitis, we should go for a brain biopsy, meningeal biopsy, or lymph node biopsy, or any biopsy from the FDG avid lesion. So how to clinical approach? Because in reversible dementia, we have to exclude that there is a no reversible possibility. There is no investigation which is positive and after reversal, like hyponatremia, like SDH, like brain tumor, like cryptococcal meningitis, like autoimmune encephalitis. After exclusion of everything, we can label it as that it is reversible dementia. So whenever we think of onset is acute or chronic, we have to go for an CT or MRI brain. Then the second, if it is chronic, the most likely rule out all biochemical abnormalities. Then we have to find out, is this abnormality is related with the diagnosis or related with the clinical approach or not? And if it is related, then treat it treat it in a specifically manner. And if it's not related, then just keep and follow up, and see whether there is a gradual deterioration, rapid deterioration, or stable for last 6 months, for next 6 months. If the patient remain stable for next 3 to 6 months, then chances is that it's more of a degenerative dementia, not irreversible dementia. And if there is a rapid deterioration, there is a chances that it may be associated with reversible dementia. So the final take-home message: every case of dementia should undergo neuroimaging and all biochemical testing, because the chances out of 10 irreversible case of dementia, we can pick up 2 cases of reversible dementia, and all reversible pathologies should be ruled out, and treatment plans should be individualized as per the cause of the dementia. Thank you, sir.
Thank you, Dr. Mukesh.
Welcome,
In
sir.
fact, the reversible dementia could not have been easier than what you have said. In
Sir.
20 minutes time, you are really enlightened us so wonderfully. It looked as a very difficult topic, and once you distributed the two groups, one irreversible and second reversible, I think the concentration on reversible dementia made very, very clear. Such a
Sir.
wonderful diction and very clear, and made it so easy. Of course, we are short of advanced investigations, but then many times, as you have impressed, a clinical history and normal examination can rule out in about, say, 50% of patients. Only
Yes.
50% of them will require elaborate investigation.
Yes,
If
sir.
there are any questions, Dr. Behra, if there are any questions for Dr. Mukesh, it's a difficult topic, I know, but then if there are any questions. And the cases which you have shown are exclusive. They are very wonderful cases.
It's a running case in last 2 months, sir. We have seen whatever in last 2 months, I presented in that fashion.
Okay. Thank you very much, Dr. Mukesh. I don't think there are any questions in the chat box, because I think once you have told about this, people will think about it again, and then next time when we meet, we will have questions for that.
Definitely,
Thank you
sir.
very much, sir. Thank you.
Thank you, sir. Thank you, sir.